Thanks everyone for joining and welcome. Hello and welcome to our monthly seminar. My name is Dr. Chad Achenbach. I'm the Associate Director for the Robert J. Havey MD Institute for Global Health here at Northwestern. And I'm also a professor of medicine and in infectious diseases. And I'm also in the Department of Preventive Medicine and Biomedical Engineering at Northwestern University, Feinberg School of Medicine. So thanks for taking the time to join us this afternoon for our latest installment of the Havey Institute for Global Health's IGH seminar series. This is a special one because we're hosted in partnership with the Potasnik Longevity Institute. And our talk today is From Recipients to Co-Creators, Community-Driven Solutions for Public Health, Leveraging Social Innovation and Co-Creation to Address Non-Communicable Diseases in Low-Income Settings. I'm joined today with our co-hosts, Dr. John Wilkins and Kathleen Howard, that are from the Potasnik Longevity Institute Human Longevity Lab here at Northwestern. So please take a moment to follow us on LinkedIn and Facebook if you do not do so already. We're also on Blue Sky and Instagram, and our handle is at FSM Global Health. In addition, we welcome you to become an Institute member to receive access to specialized resources and services that support research infrastructure. For more information, you can visit us at the website, globalhealth.northwestern.edu/members. So the Havey Institute for Global Health and the Longevity Institute are thrilled to co-host longtime collaborator, Professor René English from Stellenbosch University in South Africa for this special seminar. Professor English is a medical doctor and public health medicine specialist. She's currently the head of the Health Systems and Public Health Division in the Department of Global Health at the Faculty of Medicine and Health Sciences at Stellenbosch University in South Africa. Many of us got opportunities to spend a little time there in Stellenbosch this past March, and I know many of you got to potentially meet Dr. English, so we're very excited. She's served on the South African Health Ministerial Task Team for Human Resources for Health and on the Lancet National Commission on High Quality Health Systems in South Africa. So we welcome you to submit questions through the Q&A feature. So make sure to do it through the Q&A feature, not in the chat. So use that Q&A at the bottom right-hand center of your screen, corner of your screen throughout the presentation, and put your questions in there. But now, Professor English, I turn it over to you for your talk. Thanks so much.
Thank you very much for the opportunity to be here today. I just wanted to confirm that you are able to hear me.
Yeah, you sound great. Really clear.
Okay, excellent. Thank you. And thank you very much for the invitation. It really is an honor and a pleasure to be here. Just one correction. I think it's probably a budding relationship that will be formed with this institute, but certainly a long-standing relationship with Stellenbosch University. And as you said, I was really very happy and privileged to be part of the joint session that was held in South Africa in the first part of the year. So happy to be here. So I will dive straight into my presentation, and thank you for introducing the topic. And what it is it's just a portion, it's a reflection on a portion of a broader piece of work that I am doing at community level within our division, within our department. And so what the purpose of this presentation will be to reflect on a 5-year period where we embarked as a set of academics and community members. We embarked on a co-creation journey, and we established what is referred to as the Public Health and Social Innovation Hub. And what we aim to do through that hub is to address key community-level health challenges in a particular setting, which in this case is a low-income setting in South Africa. And we hope to look at it from the perspective of both an academic lens and a community lens. And the hub was first conceptualized in 2019, and I do want to acknowledge that the idea and the growth of the hub was very much supported by our university through its social impact funding. And I would like to acknowledge the team. So as you can see, the team is on the slide, and that is from one of our most recent events. And I do want to acknowledge Ms. Stacey Blaus, who's on the slide. She's a key team co-lead, but she is also a new mom. And so she's on maternity leave. She was on maternity leave during that activity. She's not in the picture, and we needed to find a way to get her onto the slide so that we can give acknowledgement where acknowledgement is due. And so the overview of this presentation, I'll just provide a very brief introduction to our environment. I'm assuming that not everyone on the call is familiar, on the webinar is familiar with our environment at the university. Very brief background of this particular project, and then I will outline this co-creation journey, and then I will link the findings of our reflections and the lessons learned to what exists in the evidence around this kind of engagement that one has with communities. And so as you can see on the slide, Stellenbosch University has been around for over a century, and most people who are familiar with South Africa and Cape Town think that the medical school, the Faculty of Medicine and Health Sciences, is located within Stellenbosch town, but it's actually located a couple of kilometers away, and it's been in existence for 68 years, and that's where I'm based. And you'll see on the far right the new BMRI building, Biomedical Research Institute. And this is our department, and you can see that in our department we have a very big department. There's quite a lot happening in our department. We have a division of health systems and public health, which I lead, and then located within my division is the African Cancer Institute. And then we have the Division of Human Nutrition, Epi and Biostats. We also have the Institute of Life Course Health Research. We have a Rural Health Center, and we also have a Division of Disability and Rehabilitation Studies, which focuses more on disability in terms of hearing, sight, and also in terms of Indigenous knowledge systems. This is just a snapshot of my division, not meant to go through everything, but in our division, we focus on health systems and services research, public health, and we also have occupational medicine. We are a very small team, but we are a very busy team, and we are also linked to our local health department through what they call joint appointments. So 4 staff members are on the right of the slide, work part of their time within the health services and part of their time within the academic setting. So in terms of background, I think it's no secret that South Africa is considered the most unequal country in the world. And this is such a well-known picture for us in South Africa. And it displays very well the realities of what people face in our country. And 80% of our population do not have any medical aid coverage and therefore have to seek health services within the public sector. It is also this large group of people who often live in the lowest income settings within South Africa. And so bringing it now to the Western Cape, where I am based, where Stellenbosch University is based, and where the work that we do emanates from, like the rest of South Africa, we are faced with a quadruple burden of disease. So you can see the difference between 2009 and 2006. South Africa had very high prevalence of HIV and TB, and we still do. But over time, you can see the epidemiological transitions taking place with cancer and other non-communicable diseases, as well as diabetes prevalence is increasing, or at least the burden thereof increasing. And then in South Africa, particularly in males, as you can see, compared to females, but overall we have a high burden of injuries, whether they be intentional or unintentional. And that is not only what our health services face, but that is what those who live in the communities face in terms of their health status. And so we think about it in terms of the backdrop of the quadruple burden of disease, and we bring it down to the Bishop Lavis community. So this is as I said earlier, a low-income community situated in Cape Town. And historically, it is considered to be a community to whom people of color, and in South Africa, we call mixed-raced people colored people. So it's typically colored people who live in this area, and they've mainly been forcefully removed from which are now considered white areas, or were considered white areas during the apartheid regime. And this community formed, and this community has always been known to be an active community with many activists and advocates for health over the years. And this community has a very long-standing relationship with Stellenbosch University, particularly our Faculty of Medicine and Health Sciences. And the relationship extends to the extent that we have our students placed within the health facility. We also have a rehabilitation center that is attached to the health facility. And there's a very strong history of the university having been instrumental in initiating and now still running that center. And so the way that the university thinks about these engagements with communities is through the lens of a quadruple helix towards societal change. And that is written into our social impact policies, and that underpins the social impact initiatives within our university. And so as we as a small team went into the community and thought about how do we start engaging with them, it was using the lens of the quadruple helix and how can academia and communities and other sectors work together? How can we learn from each other? How can we create linkages across the strands of the helix towards strengthened local health systems? And so the 5-year journey started when I was first employed at the university. So my background was having worked a little bit in clinical medicine, then having gone to public health and specialized working within management structures, and then a large NGO working throughout the country, and then segueing back into academia. And when I joined, one of the first activities that I participated in was a partnership day in the Bishop Lavis community. And it was there that I met a group of volunteers who ran what they call street committees. So each volunteer was responsible for a street, and they saw to the health and other social issues within the street, playing advocacy, health promotion, advocates' role. And a lot of the work that they did was organic. It was things that they saw that they wanted to address and change within their communities. And we started a partnership, and it started off being quite informal. Later on, it moved to more formal engagements. We had a number of dialogues, and we eventually got to a point where we said we would like to collectively address the wicked public health problem of non-communicable diseases within that community. So we started thinking about, and I'm particularly interested in design thinking and social innovation, and work in a different way with communities, and how do we shift our focus from more traditional research. And we had a lot of challenges getting ethics approval, lots of questions, how, why, there's no clear outcomes for this project, there's no clear methodology, and that in itself was a very interesting journey that we underwent. But nothing prepared us for COVID-19. And when COVID-19 came and we had a severe lockdown in our country, that suspended the ability to meet face-to-face, and we had to find different ways to engage, but we also changed focus. And so as you can see on the slide, we engaged in capacity building and dialogues in 2020, where we spent a lot of time virtually working with this team. When we were able to meet face-to-face, we worked with them. But that presentation is a project in itself, and I won't be focusing on that much today. Instead, I will move on to focus more on the design thinking process and this engagement and co-creation that we've had over time. And so I'll start with the Women's Wellness Day. So after we engaged with COVID-19 and restrictions were lifted, and we sort of reached some new level of normality, the question again arose in terms of what are you going to do about the needs that we have in the community? Because women need to be empowered, women run the street committees. How are we going to start to solve the problem? And that led us to co-create a Women's Health and Wellness Day. But for this Wellness Day, it was very much the idea given by the community and us as the academics coming in and saying, this is how we think you should do it. This is what we're going to do. Who should we bring in? What should we talk about? But we did a lot of the organizing, and we brought faculty members in, and we held the Women's Day, and we had our specialists come and speak about a range of women's health issues. It was a very successful day. We had over 100 women. We had testing done, and we in fact were able to assist with the diagnosis of diabetes in a number of women as part of our screening program. in collaboration with local NGOs, but also our local health facility. But more importantly, we diagnosed 2 cases of malignant hypertension just in a Women's Day screening event in a community. Both women were referred immediately to the local health facility. And the one woman still talks about how grateful she was that this was detected at that. So here are some pictures of the testing we did. And we wanted to hear their voices, so we spoke about putting the public into public health. So what I'm going to talk about now is the next process that builds on our initial idea that we had in 2019 about shifting our focus to non-communicable diseases. So after the Women's Wellness Workshop, it was quite clear, well, what are we doing about non-communicable diseases? And so over time, we engaged in a number of activities, and I'm just going to take us through that chronologically. So first of all, just what is design thinking? And many of you may know very well what that is, but I really like this quotation that speaks about expert blindness, and I'll come back to this again. The idea that things are easy when we know them really well. And so us as researchers, we know a lot of information, we get a lot of information, but often one can think of it in terms of uncertainty. We see patterns, we have some insights, and now we need to design something to respond to that, but we need to be able to be clear and have a focus on what it is we are designing for, because the design process is not predictable. And so design thinking, and I think it was a useful journey for me as well to go through learning how to do design thinking and then doing it myself, is that the process of design thinking also capacitates the participant to learn how to do this themselves, so that they can be the ability to take this idea of co-creating with others and building on it. And so design thinking, as is written on the slide, allows participants who are not formally trained as designers to learn and use the tools and protocols to address targeted public health, patient, caregiver, economic, or clinical challenges. And the cornerstone of that is extreme stakeholder empathy. So the question is, who are you designing for? What are you designing for that person? But most importantly, the person or the people that you're designing for should really be in the room designing for themselves too. And it's a bringing together of the knowledge so that there is the reaching of a common understanding, but really seeing the world from the point of view of the person. So in this case, it was, what are the needs, the thoughts of those who live within the Bishop Lavis community? And so we brought together a range of stakeholders who represented the 4 strands of the quadruple helix, many of them local, from the local health facility, from local civil society, and then also the community members. And this is a very typical graphical display of the design thinking process. Again, many of you may be familiar with it. And one starts with a trigger. And the trigger in this case was really the Women's Health Day and our initial discussions around, and then of course all the things that came out of COVID in terms of who was at risk of dying or getting severe illness. And it was about, we have a problem and we need to address it. And so we brought everybody into the room, and then we engaged in this divergence exercise where we empathize and we put ourselves in the shoes of those who live in Bishop Lavis, and we ask, what are the experiences? And this process, at each point, we brought members of the community in. So we would brainstorm, we would think, we would bring members from the community in, and we'd say, what do you think? What are your ideas? So that we could find the right problem and distill the right problem. And eventually, collectively, we got to the problem statement, which was, how might we empower women to drive non-communicable disease prevention within their homes and their communities? And this was a 3-day workshop, and we went through the entire process through to prototyping. And as I said earlier, we have the community inputs, and the prototypes are these ideas that we form where we present it in a physical way. And for us, it was just using toys as you can see on the slide, lots of thinking, lots of brainstorming, lots of discussion, systematically being taken through the process, and then using toys to build an actual prototype of your idea, and then calling the community in, describing your idea, and getting their inputs. And so there were 4 prototypes, but I want to bring your attention to this one prototype where you can see on the right-hand side, there's what is supposed to be a football field with open space and what looks like a couple of buildings. And this prototype, the co-creation, was having a community-based wellness day that will raise awareness of non-communicable diseases. But there were other insights that we gained from this workshop, and they were, first of all, that community perspectives are important. Not only is it about how do we talk to communities, but it's that their voices matter. And that when we make policies, and this comes back to expert blindness, what we think they need is not always what they need, or proposed solutions are not always feasible, wanted, or needed. And one of the policymakers, a very high-level manager, reflected and said, I thought that I knew what the solutions were until we presented a solution to the community, and they said that will never work. And so an example was given of how the community can use videos and movies and play it in the waiting rooms and learn how to cook. And the moment they presented this prototype, the community member said, we can't do that. We don't have money to buy that food. That's not the kind of food we would buy. That food's expensive. And it led to that team having to rethink the entire approach to the solution. But that's the people who make the policies. But also the method created opportunities for dialogue, for thinking, for iterative discussions and scaffolding the way that we thought, but also for distributing power, and that I'll pick up on later again. And so we reconnected with the team because part of the 5-year journey is also that life happens and that this process of working together comes with stops and starts. And so we reconnected with the team after we were able to reflect and say, well, how are we going to take things forward? And we decided, let's pick up on what we had done at the design thinking workshop. But by then we had some new members join. So it was no longer just members from this group called the Bishop Lavis Action Committee, where they have street committees. There were others now representing the local community police forum, key leaders in the community. And so what we did was we played what I called the long game. So I took the whole co-creation process and just stretched it out over time with lots of debate, lots of dialogue, lots of opportunities to think through what are the real problems in the community, what are the real solutions. And here are some examples of the many, many sessions that we had. We met every second week to think through and plan through what the solutions were. And so again, we looked at finding the right problem, but we also used research, evidence and focus group discussions, did analysis, brought others in to think through what are the problems and how can we start to solve the problem in a community which itself is diverse and where there are different problems in different parts of the community. And so when we got to the development of a statement, because we came right back to how might we empower women to drive NCD prevention within their homes, I asked them to map the areas in their community where the problems are. And they must tell me, what are the issues in this part of the community? What's the issue in that part? And we need an aerial view. And the value of this process was that we were able to reflect and get the community members to think through the answers. And I was quite taken aback that the community stopped, and you can see the slide here that says the problem assumptions. And so what they experienced was an aha moment, really, where they said, oh, we actually don't know. And so they'd been trying to communicate there's a problem, and they were getting frustrated. No one is solving our problems. No one is coming to do anything. But when I pressed them for, tell me where's the problem, show me the problem, they said, oh, we don't know. And we identified that there's an information gap. They do not have access to data. They don't know what happens to health data. They don't know where to find the data. They haven't been engaging with a local health facility to understand data. They didn't even know where to start. And that then led to us bringing in a range of managers and others who work within the district level to come and speak to them and present the data from the local health facility, from the district, and explain how data works. They were also able to understand that they weren't able to get death data because of how we collect death data and how death data is reported and who's responsible for death data, for example. And it was an eye-opening experience, but also a concerning experience, because they had then indicated and said, well, we don't believe the data. Fascinating. And out of this process, we met again, spoke again, and they felt eventually sufficiently capacitated to understand the problem and say, well, clearly the data shows that we really do have a problem with diabetes, and we really do have a problem with hypertension, and we have an apathy in the community. And so they proposed the Community Wellness Day. And it was very interesting to map this process compared to the other design thinking process that took place. And again, as an academic, I came in because I was part of designing the last Wellness Day, and I came with my ideas, and they said, no, we don't want your ideas. We are going to run our day like this. And so again, we sat down and said, well, let's co-create the day. And I'll come back again to what that moment meant in this relationship over the 5 years. And so here's a picture of the Wellness Day. It was a community-led Wellness Day. We did support them, but we supported them with minor things. They planned the day, they thought through the day, they gathered their community members and decided how they were going to run this day. So they got the local police in, they got the local neighborhood watch involved, they got local NGOs involved, they got the traffic officials involved. And we got people to sign up, and they indicated, we want to do a 5-kilometer walk in the community. And this is a community that currently has a high level of violence. So the quadruple burden of disease plays itself out in this community. There's a lot of gang violence, a lot of turf war over drugs. So walking in a community like this is something that they do frequently, but is something that would kind of make you think, oh, is that safe to do in this community? But that's what they wanted to do. And so here are some pictures of the walk. And one of the members cast the vision and said, I see a sports field. And that member wasn't at our initial design workshop, and said, I see this high school students walking in front as the cadets. They need to march in front. And so this is how it played out. We ended up testing about 115 people. We had 15 HIV tests, which in a community where there's a walk-in to participate in a wellness day was actually quite a lot. We also got our colleagues from the university to come and speak to the high school students about mental health. And you can see there's a large group of people who participated. And I want to highlight SAPRIN in the middle, because Bishop Lavis is also a demographic and health surveillance site, which is fledgling at the moment, and we are part of it. And so they've come on board to see how can we build relationships where we can use the university to collect the data. And so I'll just play a short video, which I now hope will play. Hope you
Hi there, my name is Melanie Erasmus. I'm the MC for the Women's Health event today. I'm here because I've been involved with the Bishop Lavis Black community for a while. I did the event a few years ago and I'm so glad to be back working with them again, making a difference.
Hi, I'm Chloe Lyosa and I'm one of the candidate legal practitioners at the Stellenbosch University Law Clinic. And today we're here at the Wellness Day just to provide some legal advice to the members of the Bishop Lavis community. And the reason why it's so important for us to be involved in a day like today is because it is important to provide access to justice for everyone.
Abrams. I joined the public health group because I think that health is very important, especially in a low-income community where you don't always have access to resources. The reason we did the public health screening today is that few people are unaware of their health status, and that needs to change. This event today was about just doing screening people to see their health status, how their health status are. And yeah, that is how the planning of this day, I think we started in the planning for this day. It was a few days that was rescheduled, but we made it to today, and we're proud of ourselves to say we finally came to do this day.
Okay, thank you. And we also collaborated with a local high school and they made their premises available. And in fact, one of the speakers was a learner at that high school. And so the principal was delighted that the learner is still very involved in the community. And so now for some reflections on experiences and evidence. And so I'm just shifting the focus of the presentation a little bit. So social innovation is defined as a dynamic process of strategically developing and implementing inventive ideas, strategies, interventions aimed at proactively addressing prevalent social issues and instigating positive transformative change. And there are many definitions for social innovation, but as a concept, it's also understood differently by different disciplines. But what I like about this particular graphic and the source of the graphics on the slide is that it highlights the way this idea of collaboration and co-creation and social impact and user-centeredness or empathy, centeredness, creativity, and innovation fits into a broader understanding of social innovation. And one particular way of thinking about social innovation is not coming in and saying, what do we do differently in terms of what do we bring to the community, but instead taking an assets-based approach and saying, well, what's in the community and how do we build on that? And so moving from the social innovation to co-creation, in the literature, there are some authors or researchers who write about co-creation. And Pierce in 2020, drawing on the work of Greenhalgh and Anderson, speaks about it in two ways. The first being that co-creation is about new knowledge generation, and the quotation is collaborative generation of knowledge by academics working alongside stakeholders from other sectors. But Anderson also sees it as program or policy delivery, where there's a process whereby researchers and stakeholders jointly contribute to this idea of ideation, planning, implementation, evaluating new services and systems. And the idea is about optimizing the impact of research findings. And so this is taking a very research public health lens to this understanding of co-creation. And Fitzpatrick talks about it, the relational nature thereof, the power sharing nature thereof, and the building of these trusting relationships where power is truly shared for effective co-creation. And then, as you can see from the slides, it requires a diverse set of stakeholders, collective leadership, transparency, and honesty about the research process. So this is what comes out of the literature. And so what we did last year as a group is we took a reflective approach to thinking about, well, how far have we come? Because we'd been working all the time and got to a point where we realized that we've actually moved from being participants in a process or recipients of a process in the case of the community to being partners and co-creators. And so we asked ourselves, well, what have the enablers been? What have some of the challenges been? And so the first one, we did then eventually we did a thematic analysis of the reflections and identified the value and importance of time. That not only the ways in which we worked, but time itself was very important for building trust. We were very open and honest with one another. We spoke, the community, as I think many of you know, they speak their mind, and they would tell us when we were out of line. So that really was something that cannot be overlooked. And then this strengthening of bonds, where in this particular group we had mutual respect, lots of transparency. So this entire project was run on a very small budget, very, very, very small. But we were able to say to the community from the start, we don't really have money to run this project, but we want to work with you because we have an interest and we see the impact that we can make. And so it gave us all a sense of what to expect, what we can do, what we can't do. And as our social impact vice dean Dr. Fish always reminded us, we are not a charity organization, we're a university. And so we would speak about what that meant when we work together in commitment and authenticity. And for us, we are from communities like that, so we were able to speak the local language and the local lingua. We had insight and understanding to the community in the communities, and so there was a natural strengthening of the bonds that were added by that. And then we found that over time, voice, power, and agency grew amongst the community members, and that we navigated power differentials in a bi-directional way. But the multiple engagements fostered agency, where we went every second week, we went to the community, and we didn't want to bring them to the campus. We said, no, don't come to us, we'll come to you. We want to be able to see what it's like. We want to be there with you. And then resources, we reflected that we try to always be available, as I said, and we try to be clear around what our roles were. We're not here to solve problems. We have our expertise, we have our knowledge, but you have your knowledge too. And then the tension between rigor and pragmatism as researchers was one that was very difficult for us to negotiate. All of this took lots of time, very hard to publish some of this work, which took so long to do, but also very hard to manage just getting something done, doing something versus getting ethics application, applying for your and then conducting your research in that way. And so what we also found is that the community champions are critical, that dedication on the part of the community members, they came every week, and authenticity and continuity from the academic key enablers as we moved from becoming participants in a process to co-creators. And so Longworth's done a review and looked at specific challenges around co-creation in low and middle income countries and speaks to understanding context and how important it is. And we can attest to that from our reflection. Also the considerations of power dynamics, social hierarchies, which we knowingly and unknowingly navigated. And then time and effort intensity compounded by limited resource often is a challenge which we faced. But the benefits, positive emotional outcomes, increased self-management in terms of us all taking responsibility for ourselves. We also could really refine and are in the process of continually refining our research questions and approach. And it certainly has had a positive impact on us as researchers. And so again, just to summarize more broadly the challenges in terms and looking at it in terms of what's come out of Singh's work, we also did a review, and it resonates with the findings of other work, but also resonates with what we found in our work. But what I can say is that this group of individuals who are leaders in their community are proactive within themselves and have been doing this for a very long time. And in our discussions, we often speak about how they don't really need us, but having us as academics adds a layer of value to what they do. And we saw that play out repeatedly in our engagement. And so just in terms of its implications for implementation science, where there's a shift from linear and controlled production models to this more iterative, participatory and complex models with the design and creation of solutions and interventions directly in the real world. There's a re-emphasis on the importance of involving stakeholders as early as possible, and how co-creation can increase the successful uptake of evidence-based interventions and practices through this meaningful and deep engagement of key stakeholders. And this ongoing process evaluation, which we would call it, is very important. And we are doing process evaluation alongside the project whilst considering things like positionality, being a participant researcher in the process. So the way forward for the hub. Ongoing evaluation in, as I said earlier, we continue the process of iteration and prototyping with a focus on non-communicable diseases and wellness. And I added aging, and Dr. Wilkins is here and in the call. And when Northwestern University came out to meet us, I brought some of the community members with to be part of the partnership days that we had. And when they sat in on the presentations on aging, as I drove them home in the car, they turned around and said to me, when are we going to have a study on aging? How do we get involved? And so again, it speaks to the interest in that community, but it speaks to the fire that they have and their understanding of the intersection between research, evidence, and what that can mean for them as the community. We're also planning a series of policy advocacy workshops to build the community's capacity. We are going to plan another wellness day. And linked to the policy advocacy, and so I've included some pictures on the side. So we have a WhatsApp group, and they've been complaining about people who stand in the rain on the mornings before the health facility opens. The Cape Town is known for its brutal winters. And this is just a picture that they sent. So I said, well, you keep complaining, but I don't ever see pictures. Where are the pictures? So they sent some pictures in the week when it was raining quite a bit. And so this is what we'll try and tackle next in terms of working closely with the various stakeholders to identify some problem, a solution which exists, and we just need to find ways to use policy advocacy and co-creation to solve the problems. And so it's an ongoing process. There's a lot that will be done and can be done over the next few weeks, and we are always looking for like-minded people to participate in our processes. And I'm very humbled by working with the community, and very happy to be here and be part of this presentation. So I think that is the end of my presentation. Here are my references. Thank you very much.
Thank you very much.
I'd like to acknowledge everyone. Thank you.
Thank you very much, Professor English. This is Rob Murphy. I'm the Executive Director here, and I'm going to lead the question and answer session. First of all, thank you very much for speaking with our group today about your project and our relationships between the institutions. If anyone has any questions, please use the question and feature, Q&A feature on the screen below, and we can ask your questions. I think maybe to start off, I'll ask my co-hosts if they have any comments or questions themselves, John or Kathleen.
Yeah, sure. Thank you, Renee. A really, really fantastic talk and very helpful to kind of see the scope of all the stuff you're working on. Really, really great stuff. I guess just a few questions. You probably haven't had a chance to do this, but I remember when I was there, you were sort of educating me about Bishop Lavis and how motivated and organized Bishop Lavis is for a township in South Africa. Do you have a sense of how many of the lessons that you've taken away from your work with that community might be generalizable to other townships in the area, or is that just too hard of a question to answer at this point? Because you just haven't had a chance to to test it.
So I'm having some connectivity problems on my side. I only heard part of your question. Would it be possible for me to switch off my video for a short while until
Sure.
it stabilizes? And would you mind repeating the question? I do apologize. I
Not
only
at
got
all.
bits and
Not at all.
pieces. Okay.
So Renee, what I remember when I was there, you were educating me or teaching me about Bishop Lavis and how motivated and actually relatively organized that community was. And I'm curious what your gestalt is. I mean, do you have a sense that many of the lessons around implementation, acceptability that you've learned in Bishop Lavis, do you find, or do you think that they're likely generalizable to other townships in, let's say, the Stellenbosch area or South Africa more broadly?
Yes. Would you like me to answer this question now?
Yeah.
Or
Yes.
to
Yeah,
take
please.
a few others? All right. Thank you very much. Yes and no. So let me go back to, first of all, one of the frameworks that we used to think through this work. I haven't mentioned it, but it's work done by someone called Leask. And they speak about the co-creation process and then speak about scale up and speak about the importance of adopting a particular approach to scale up and testing whether the approach you've used is going to be useful in another setting. So the idea was actually initially to scale up very quickly to another community, but we learned that, and then to learn those lessons and to get a sense of how generalizable is it to scale up to another community. But then at the same time, COVID happened, but also we realized, oh gosh, it's taking really long to build the relationship. But having said that, when I presented this work at a particular conference, somebody who is a community leader in a very different community approached me and said, can you please come and do this work in our community, because this is the approach that is missing in our community. The third point that I want to make towards this is that in the discussions that have been taking place as we move to implement universal health coverage in our country at the moment, as we try to introduce community-oriented primary health care, a lot of the discussions are exactly about, well, how do we get the community to shift and how do we get the community to change? And the evidence that seems to be emerging is through a co-creation process like this. It may look different in each community, but it involves sitting down, meeting, talking, engaging, planning, and trying to determine how to solve the problems. Some of the communities are quite homogeneous in terms of if what you can do in one community you're able to do in another, and others are different. The last point I want to make is I just want to draw on some personal experiences around it, is that I was part of a project where we had to do community engagement across 6 communities, which were quite diverse. And the discussion and the engagement and this approach was the approach that worked the best, which is partly why for me, it sparked the idea of, well, I think we should be dialoguing more, we should be talking more, and we should go in a more sort of humble, authentic way and co-create with the community. But how we got into the communities differed. So some communities have very strong leadership, and we had to go in through the leadership. They would not allow us into the community, whereas others we had to find the leaders in the community. So yes, and in the my feeling is that this is one of the missing pieces in terms of how. Having said that, I'm not the only one who does work like this. Many people do work like this. Many people in our division do work like this. Many people in the world does work like this. And so I'm just reflecting on our approach in this community that I know very well. So I do think it is more about a model, because one of the success factors, as I said earlier, is that we understand the community because we grew up in similar communities. So we understand how they think, how they talk, and we speak the lingo with them. Others may not understand that, but similarly, I may go into another community and I won't be able to possibly connect as well because I'm not from that community. Thank you.
Great. Thank you so much.
Any other questions? Or Kathleen, any comment or question from you?
Well, I don't have any question, but I do want to thank Professor English. Every time I heard you speak in Stellenbosch when Dr. Wilkins and I were down, and I continue to be so impressed with the work that you do within the community. And we came back from our trip thinking that we're going to learn a great amount from you folks there in terms of how to create community engagement as we look forward to our collaboration on aging moving forward. So I continue to be so impressed every time I hear you speak. So thank you so much for that. We're really looking forward to working with you folks down there. So
Yeah,
Thank you
maybe to add on to that, Renee, if you don't mind, what do you suggest for us in our collaboration together with our Northwestern collaboration with Stellenbosch? We had a great meeting a couple months ago, and where do you see that going? Where would you like to see it go? Let's put it that way.
All right, thank you. I feel slightly unqualified to answer the question because there's so many other layers about me. But what I thought, and may even have said, I can't remember, but what would be beneficial and wonderful is if we can have ongoing conversations across our entities. So we had our department, so I'm speaking specifically about global health now. We had our department present, we have the Northwestern and the various pieces of work that you do around global health. And just having conversations, just talking about what do you do, what are the opportunities, sharing lessons learned, sharing opportunities. That, I think, if I can draw on the model that I just presented, may in turn build trust and familiarity, and we'll be able to find commonalities with each other. So virtual engagements, if we could do some staff exchanges as well, if possible, or visit out to you, and then find that those few touch points, and if I may, I think John's really been trying to reach out and has done quite a good job of reaching out to some of the colleagues to build collaboration, and I'm sure others have done that too. But that would be a good, actionable step to take.
Mm-hmm. No, I think it's very practical too.
Yeah.
Because regardless of what's going on in between our governments, I think we want to keep our university relationship maybe stronger than ever, really.
Yes.
We know the limitations of the central government here in the United States now, and I'm sure you are aware of the limitations of the South African government.
Yeah.
But anyhow, yeah, we want to keep this moving and make it stronger and stronger. So, but we're really pretty much at the top of the hour. I want to thank Professor English, Renee English, for sharing her insight today and expertise. I want to thank the audience for joining us, and I want to thank my co-hosts, John Wilkins and Kathleen Howard, for their comments and leading a discussion here. We invite you to join us at our next IGH seminar, which will also be by Zoom on Wednesday, September 10th. So there's no seminar in August. The seminar will be presented by Amy Van Pelt. She's assistant professor in the Department of Medical Social Sciences and Associate Director of Research at the Ryan Family Center for Global Primary Care at the Havey Institute for Global Health. And you can register via our newsletter, Planet Purple, or our social media pages. Again, thank you for joining us, for all of you for joining us today. A recording of the webinar will be available online and will be shared via our newsletter. And this concludes today's webinar. Thank you very much.
Thank you. Enjoy your day.
Thank you.